Well, hello, and welcome to the New York Gastroenterology Associates webinar series, a series in which we put a pause in our day to get to speak to you directly about important health issues. New York Gastroenterology Associates, of course, is your local group of gastroenterologists that's been serving the greater tri-state area for over 25 years. This webinar series, of course, has existed for a number of months. You might have seen this best kept secret on our webpage under the Our Practice news section. And you can go back and go through some important, amazing topics from Dr. Kornbluth and Tamara Friedman. Today's topic, of course, will be IBS. It is a real pain in the gut. My name is Ugo Iroku. I'm one of your local gastroenterologists here. I personally have an interest in colonoscopies, upper endoscopies, community health, and empowering my patients to make important health gut decisions. Tonight's series will be led by our very own Dr. Fredo, Laura Fredo. Laura Fredo is an expert in a number of gastroenterology subspecialties, including inflammatory bowel disease, IBS, women's health, and preventative GI health issues. To start off with, of course, I'd just like to go over some housekeeping issues. As you can see, there's a Q&A function. This is a function in which if you click on it, you can enter questions. That we will have one of our associates, Dr. Yang, answering some questions in that forum, but most of those will be saved for our speaker for today, Laura Fredo, and we'll address those at the end of our topic, or at the end of her series of slides. If you have any technical questions, of course, please click on the raise hand function, and we'll be able to communicate with you and help you. So without further ado, we'd like to introduce Dr. Laura Fredo.
Thank you so much, Dr. Iroku. Hello, everyone. Good evening. Welcome to our webinar. So thank you for the introduction. My name is Dr. Laura Fredo. I'm one of the gastroenterologists at New York Gastroenterology Associates, and I'm very excited to be speaking with you tonight about irritable bowel syndrome, a real pain in the gut. This is one of the most common syndromes that we deal with as gastroenterologists, and primary care doctors see this a lot too. Tonight, I hope to go over the basics of it, kind of try to demystify what goes on in the brain and the gut interaction with IBS. And then I look forward to taking some of your questions at the end with a nice discussion with Dr. Iroku. This is just a reminder, this will be recorded, and you'll be able to watch it later when it's posted on our website. I should plan to talk hopefully for only about 40 minutes, and then maybe faster, and then we'll open up to the questions. The agenda for tonight, first I will be covering what is IBS, what are the symptoms of IBS, very importantly, when is it not IBS? We'll go over some of the differential that it could be and what we want to look out for. What are the causes? How is it diagnosed? What are the treatments? And again, like I said, we'll get into the discussion. So let's dive in. What is IBS and what are the symptoms? IBS was classically known as a functional GI disorder, but now we use the term a disorder of the gut-brain interaction. Now, what does that mean? Functional gastrointestinal disorders are an umbrella term that kind of goes over different syndromes where if you did a bunch of testing, if you looked in their stomach with a camera, with an endoscopy, you did a colonoscopy, you did a CAT scan, blood work, stool studies, all these studies actually come back normal. It can be very frustrating for patients because they want an answer to why they're having symptoms. But this doesn't mean that it's all in their head or there's nothing going on. It means the function of the gut, what's actually going on in their digestive tract is triggering certain symptoms. And we believe this stems from the interaction between the way the gut, the digestive tract, and the brain are communicating with each other through this gut-brain axis. IBS is a mixed group of symptoms and a mixed group of patients. Not everyone has the same symptoms with IBS. So it can be difficult to kind of pinpoint the underlying abnormality. There are lots of different theories that we'll get into tonight that can drive the symptoms and the condition. The main things that patients have to experience to be classified as having IBS is abdominal pain and abnormal defecation. IBS is a huge burden on the healthcare system and actually has huge costs. about 30 to 50% of the patients we see as gastroenterologists are struggling with IBS. What I always want to point out is this is a chronic condition and it can significantly impact patients' quality of life. It can be very frustrating, again, if you don't have a doctor who has the finesse to explain how it manifests, because they may be brushed off and told, everything's normal, it's just IBS. But that's exactly the opposite. It is IBS, which has true origins, and we can talk about how to deal with it. The good thing about it, though, although it's chronic, it is medically benign. It's not something that progresses over time and will lead to cancer or devastating side effects. It definitely can affect your quality of life, though, so that's why it's so important to form a relationship with your treatment team to try to get you on the healing process. Again, what is IBS? It's not just in your head. So your brain and your spinal cord make up the central nervous system, but your entire digestive tract is lined by nerves. This is called the enteric nervous system. This is a network that communicates between the central nervous system and the digestive organs. This system regulates basically all parts of digestion. These feedback loops regulate the way the muscles move through the digestive tract, the secretion of hormones, how fluid goes across the membranes, blood flow. It also affects how your immune system and your endocrine system function in the gut. And it can affect how we absorb nutrients and the important mucosal barrier between our body and the outside world. Common IBS symptoms include constipation, diarrhea, an alternation between the two, so sometimes being constipated and sometimes having diarrhea. Sometimes people will see mucus in their bowel movements. They'll have a sensation of incomplete bowel movements. And one of the cornerstones and symptoms that you need to have IBS is abdominal pain. Some patients also experience bloating. Now, if you're experiencing an episode of diarrhea or chronic diarrhea, but you're not really having pain, that usually doesn't classify you as IBS. Same thing with constipation. You may just have chronic constipation. So this is the time we're going to get a little graphic, have a little potty talk. We're not afraid to get down and dirty at New York Gastroenterology Associates. So we often pull out this lovely stool chart called the Bristol stool chart. This is a way that we can, have you easily identify what sort of symptoms you're experiencing. So this handy dandy stool chart basically outlines, the basics of what you'll see. Type 3 and type 4 stool that you see on here are your standard healthy average stools. So they're formed, they come out in one piece. They may have some, cracks on the edges, but otherwise they're relatively easy to pass. When you get into type 1 and 2, those fall into the constipation spectrum. So really hard or bulky stools that are sausage shaped and lumpy or maybe uncomfortable to pass, or small little, unfortunately, we like to call them rabbit pellets that come out in small little balls. And then on the other end of things, types 5, 6, and 7 are in the diarrhea spectrum. So soft blobs with clear cut edges, fluffy pieces with ragged edges that come out kind of mushy, and then of course just watery stool itself. So there is a group of smart doctors who get together every 10 years or so in Rome, in Italy, and have a discussion about these functional gastrointestinal disorders. The most recent time they got together, they made the Rome 4 diagnostic criteria. And this outlines what IBS is. And using these guidelines, your doctor can basically make a clinical diagnosis if you have irritable bowel syndrome or not. Back in the day, we used to run 1 million tests and put you through the $1 million workup. When everything came back negative, we said, oh, yep, must be IBS. But now we're much more astute and have done the studies and understand it better. And we can kind of classify you as having IBS just from taking your history alone. So IBS technically is defined as recurrent abdominal pain, on average, 1 day a week for the last 3 to 6 months. And it has to be associated with a change in defecation, a change in the stool frequency, and a change in the stool form or appearance. This chart has 3 types. There's actually 4 types. So there's IBS-C, which is chronic constipation. There's IBS-D, which is mostly diarrhea. There's IBS mixed, where you can fluctuate, flip-flop between the two. Then there's also an unclassified category where it's all over the place and you don't really fall neatly into one of these categories. By putting you in one of these categories, it just can kind of start us on the track to helping you manage your symptoms and find out what your triggers are. Who gets irritable bowel syndrome? So this is a disease that's extremely common. It occurs in up to 20% of the population, up to 16% in North America. It's much more common in younger patients. Very often we see people start to present with these symptoms when they leave their house, they start college, they're out of the home. It's much more common in women. Women get IBS twofold time compared to men. And it has been seen in patients with lower socioeconomic status. When is it not IBS? So this is a really important slide I want to highlight. When you meet with your doctor and you're getting your history taken and they're trying to figure out, could you fall into that room for criteria for IBS or not? These are the really important things we need to make sure aren't going on. So if you're having any symptoms of blood in your stool, weight loss, any abnormal labs, specifically iron deficiency, when we do a physical exam, if we notice any abnormalities, that would be a red flag sign. And as I mentioned, this is a disease of young patients. It may last your whole life, but if you're just presenting for the first time with symptoms and you're 55, 60 years old, that raises a flag in our minds and we want to investigate and see, could it be something else? Have your symptoms only been going on for 2 weeks? Probably not IBS. IBS, you need to have had symptoms for 3 to 6 months. Are the symptoms waking you up in your sleep? That's a great question to kind of distinguish. Is there something underlying inflammatory or something not related to the brain? The brain's sleeping when you're asleep, so you shouldn't have IBS symptoms that suddenly awaken you. It's really important to get a family history, so we ask about a personal or family history of celiac disease, which is the actual allergy to gluten, colon cancer, or inflammatory bowel disease, Crohn's and colitis. Food allergies are always a question patients have in relation to their symptoms. And a true food allergy, I'll explain a little later, is not IBS. So these are the conditions that the doctor definitely needs to make sure aren't going on. I specifically like to highlight one condition: older women who suddenly get watery diarrhea. It can often be something called microscopic colitis, and that's something we want to check and see if you have any risk factors for, or you're on certain medications and things like that. Food allergies are not IBS. So what I often have patients ask, they come in, they're telling me about they eat, they get abdominal pain, they suddenly have diarrhea, and they're convinced they're allergic to something. Food allergies are a very distinct entity than a food sensitivity. A food allergy is actually an immunological mediated event. Symptoms are reproducible and very rapid. So every time you're exposed to that trigger, you get these symptoms. It's extremely uncommon in adults. It happens in about 1 to 3% of adults. And these are true allergies to things like peanuts, shellfish, tree nuts, eggs. And you'll end up with symptoms that are very different than food intolerance symptoms. Itchy mouth, swollen face, swollen tongue, swelling of your lips, nausea, abdominal pain, and it could even progress to anaphylaxis. Now, it can have some overlap with IBS. You can have abdominal pain and diarrhea, but having any of these other symptoms, such as a rash, difficulty breathing, really puts you into the category of an allergy. And we would strongly encourage you to work with an allergist and probably carry around an EpiPen. What causes IBS? So, as I mentioned, IBS is a functional gastrointestinal disorder that has been now redefined as a disorder of the gut-brain interaction. This disorder then causes alterations in the gut function and gastrointestinal symptoms. And again, it's a mixed group of symptoms and a mixed group of patients. Nobody's IBS is the same. Therefore, there are lots of underlying causes and theories that have been brought up and put together to try to figure out where this comes from. There's no one specific abnormality that drives IBS. But there's definitely something to be said with these different categories on the slide here. So genetics 100% plays a role in IBS symptoms. I have had many family members, many patients tell me about their family members who, they'll say, we all have sensitive stomachs, or at the holidays, we're all in the bathroom. There's something to be said for that. There's a role of genetics. There's also a background of psychological factors that can predispose you for having IBS. Patients who have had early life trauma, patients who are in a frail psychological state at the time when they're experiencing symptoms. So if you already have a baseline of anxiety and depression, it can increase your chance of developing IBS symptoms. Patients who don't have a great social support may react differently to what they're feeling in the digestive tract, and that can trigger pain and discomfort. And there's definitely environmental triggers that can bring all these underlying problems to light. So infections, use of antibiotics, and diet, if there is a food sensitivity, that can also trigger symptoms. So all these baseline abnormalities cause a disorder with the way the brain and the gut are interacting, and thus lead to functional symptoms of the digestive tract. Motility disturbances, so this way that the speed that things move through the digestive tract. Visceral hypersensitivity. This means the gut is almost on high alert and feeling every single function of the gut in a negative manner. It can lead to altered mucosal and immune function. It can change the gut microbiome. And it can change the way your brain processes all the stimuli that's reaching it from the digestive tract. So getting into a little bit more detailed examples of these processes, specifically there's this phenomenon called central nervous system modulation. So the brain's way it receives information and processes it. So the brain and the spinal cord receive the information from the enteric nervous system of the digestive tract and process what they're experiencing. Patients with IBS have been shown to have a difference in the way they process these stimuli. They did fancy studies where they put patients under functional MRI machines, and patients with IBS, their brain lights up differently than patients without. This is really helpful because it actually sets us up for therapies to manage symptoms. It gives us a role for hypnosis, cognitive therapy, and medications. There's a theory that the microbiome is abnormal, which can contribute to IBS symptoms. We had a great talk from Tamara Freiman last month that I got to help participate with, and she helped us learn about how to keep our microbiome healthy. This is an interesting question. It's a little bit which came first, the chicken or the egg? Did having the predisposition for IBS and having IBS change the microbiome? Or is the microbiome abnormal and that enhances your IBS symptoms? This is an area of active research, and again, is a good thing because it's a potential therapeutic target. Keeping a healthy prebiotic-rich diet is very, very important. Sometimes we'll use non-absorbed antibiotics to reset the gut bacteria. And there are more studies ongoing about probiotics and fecal microbiota transplant, FMT. Probiotics actually aren't approved for IBS. Sometimes they're used, but they're not, the data is actually quite poor when it comes to probiotics. There is a phenomenon that's a separate entity, but it has a lot of overlap with IBS that we often talk about and sometimes rule out when we're working out patients with IBS. This is called small intestinal bacterial overgrowth. So this phenomenon, basically, the colon is full of bacteria, as it's supposed to be, billions and billions of bacteria. But for whatever reason, that bacteria creeps up into the small intestine and becomes overwhelmed. It's not that you have a specific infection, but you have too much bacteria in your small intestine. And when you eat certain foods, certain carbohydrates, when they hit that small intestine, the bacteria gobble it up and make gas instead of you absorbing it. And these products of digestion can lead to symptoms of distension, malabsorption, diarrhea. So this is something that, again, may, in addition, cause IBS, may be a sister to IBS, or may just be a separate entity on its own. There's another phenomenon called post-infectious IBS. So up to 33% of patients who have IBS report remembering that they had an acute diarrhea illness at the start of their symptoms. So getting an infection such as Campylobacter, Salmonella, Norwalk virus, Cryptosporidium, or Giardia can increase your risk for IBS. You're at a 3 to 7-fold increase in developing IBS after having an episode of gastroenteritis. Not everyone who gets these infections will end up getting IBS, but those people who are women, those who are younger, if you have a history of anxiety, or during your illness, if you had a prolonged fever or used antibiotics, that slightly increases your risk. So visceral hypersensitivity is an interesting topic. With IBS, some patients, their digestive tract is just on high alert. Every single stimuli that's coming through their digestive tract is giving them a noxious, a negative interpretation of those stimuli. Patients with IBS have been shown to be more likely to feel just their regular gastrointestinal sensations. They notice gas more. They notice the regular automatic contractions that are going through the digestive tract more. And often these things are triggering pain where they wouldn't in a patient without IBS. Some studies have been shown where they insert balloons in different parts of the digestive tract and blow them up. And patients with IBS report pain at much lower levels than patients without IBS. Food sensitivity is a huge part of IBS, figuring out if you have triggers to certain foods. So these food sensitivities, they may be exacerbating IBS symptoms on their own, or they may be contributing to the brain over sensationalizing these stimuli in the gut. And this is why even normal amounts of gas from certain types of food can be experienced as extremely painful for patients with IBS and can cause a lot of bloating. It can be difficult. Patients with IBS try to clean up their diet, they try to eat healthy, they're on the veggie train, and they feel like their symptoms are actually getting worse. So there is a phenomenon where certain patients have a difficult time digesting certain carbohydrates. One specific one that most people are aware of is lactose intolerance. So lactose is a type of carbohydrate that you may not have the enzyme to digest. If you're lactose intolerant, when the lactose hits the lower digestive tract, it can interact with the bacteria there, ferment, and lead to gas, bloating, diarrhea. Some people, it actually binds them up as well. That's part of other categories of carbohydrate intolerances called high FODMAP foods. I'll get into that in a little more detail on a later slide. Gluten is also one of these carbohydrates in the FODMAPs, but gluten intolerance is similar to lactose intolerance as opposed to celiac disease. As I mentioned earlier, that celiac disease is one thing we always rule out, the actual allergy to gluten. Gluten intolerance is a difficulty digesting it that doesn't cause inflammation, but causes a lot of symptoms. So figuring out if you have a certain food sensitivity is one of the cornerstones of managing IBS. Change in motility. So these are one of the key characteristics patients experience with IBS. As you eat or have a stressful situation or get more distended, your system responds. With IBS-D, you can have an increased frequency and urgency of bowel movements. And with constipation, you can have decreased frequency of bowel movements, leading to harder stool and discomfort. Another big characteristic of IBS is the psychosocial involvement. We all know stress plays a big part on our gastrointestinal symptoms. Some people feel stress as a headache. Some people, their lower back starts to hurt. And some people, it causes frank abdominal pain. Some people, it sends them to the bathroom. So we know that anxiety, stress, insomnia alone are risk factors for IBS. There may be something to be said about the stress-related hormones and how they directly influence motility and abdominal pain. These psychosocial factors also change the way patients respond to their abdominal pain. They can kind of catastrophize what they're feeling because it's really uncomfortable. And they may even seek out healthcare resources more than the average person. How is IBS diagnosed? So the most important thing that I have to stress to you is forming a therapeutic relationship with your team and having a consultation with your gastroenterologist. During that consultation, you'll have a long discussion, which involves symptoms, history, family history, triggers that you've become aware of, what your bowel habits are like, and also a physical exam. The diagnosis of IBS, again, can be made just with this consultation alone, as long as we're ruling out some of these red flags that I mentioned earlier. Routine diagnostic testing is not really recommended unless you have certain features. A lot of patients ask, should I be getting food allergy or sensitivity testing? Usually not. Usually with the elimination diet trials that we do to figure out what your triggers are, we can pinpoint what you're sensitive to and save you money and time from doing these fancy schmancy expensive food sensitivity tests. Specifically, if you're having a diarrhea predominant subtype, we do often get one round of blood work and stool studies to rule out inflammation and celiac disease, and to make sure you don't have inflammatory bowel disease. And if you have IBS with constipation, we often ask kind of hard questions about your bowel habits. If you have any signs that the muscles in the lower part of your rectum aren't functioning normally, for example, you're pushing and pushing and pushing and it feels like you're pushing up against a wall, or when you have to use help with your hand or your finger to get the stool out. These are signs that the muscles down there may actually not be properly helping you have a bowel movement. And then we'll encourage further testing like anorectal physiological testing, anorectal manometry. And this helps us rule out pelvic floor disorders and may encourage us to send you to pelvic floor physical therapy. Treatments for IBS. The most important thing, again, after the consultation and when a doctor decides you probably have IBS, is to move forward and develop a relationship with a team that can help you manage your symptoms. We're very lucky at New York Gastroenterology to have 15 gastroenterologists who manage this very regularly. We also have in-house testing for a lot of these conditions if we do decide you do need further testing. We have an amazing new team with GI trained dietitians, and we have very good relationships outside of our practice with behavioral health specialists. This team approach is really important to get at all the different aspects that can be contributing to IBS. As you're establishing these relationships, what we're trying to do is educate the patient on where their symptoms are coming from. Reassure them that although yes, your symptoms are extremely debilitating and can really affect your quality of life, they're not dangerous and they're not going to progress, and we're not missing something scary like cancer. Then we focus on what are your symptoms and how can we get you feeling better. So we address your concerns, and then we try to focus on the predominant symptoms you're having and what subtype you have. Again, IBS is a chronic condition. Symptoms can wax and wane over your life depending on what you're going through and what you're experiencing, how your diet changes, your activity level. I think this year was pretty stressful for a lot of people, and I will say I've seen a lot of IBS consultations this year. So definitely, I hope 2021, everyone's IBS is going to start calming down a little bit. There are a lot of different ways to approach the treatment options. We start with managing diet and lifestyle. Sometimes we go to medications, over the counter and prescription. We'll talk about supplements. There are some supplements that we use regularly. A lot of them are actually not very helpful or actually a little risky. So it's always important to talk about supplements with your doctor. And then getting a behavioral health team and approach to help manage symptoms and deal with symptoms is really important as well. And that's been new in the last 10 years or so, understanding how important that aspect is to the treatment. Exercise. So this is one thing that has really been shown to help with irritable bowel syndrome. Patients who participate in exercise 3 to 5 days a week actually have decreased IBS symptoms and psychological symptoms. Yoga specifically has been shown in randomized controlled trials to improve IBS symptoms. There's definitely something to be said with the deep breathing and it resetting your stress hormones and stress levels, and thus helping with your perception of pain. Walking alone has been shown to improve gastrointestinal symptoms, your negative affect, and anxiety. There is a technique called diaphragmatic breathing that I often teach my patients with lots of different gastrointestinal issues, which basically slows down your breathing and focuses on, instead of taking a big deep breath with your lungs, you're taking a nice deep belly breath. And this actually kind of resets the pain feedback loops and can kind of break the cycle. Then we get into the dietary management of IBS. So this is best carried out with a GI dietitian, because they're the best trained to help you work through these sorts of elimination diets that try to figure out what your triggers are. So FODMAPs, these are certain carbohydrates. FODMAP basically stands, it's an acronym that stands for these fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These fancy terms are basically a lot of very healthy foods, but they have certain sugars, carbohydrates that are hard to digest in certain people. So these are everything from lactose is one category, gluten is one category, but then it's things like broccoli, Brussels sprouts, onion, garlic, beans, apples, watermelon, avocado, these superfoods that are really good for you. Unfortunately, sometimes patients are very sensitive to them and have a hard time digesting them. What happens? Why is it hard to digest these? When these carbohydrates hit your digestive tract, they could increase water secretion into the intestines. They increase fermentation and can cause a lot of gas and distension, and thus can trigger meal-related symptoms, urgency, diarrhea, cramping. So what we do, again, working with our dietitian team, is we put you on a strict diet that cuts a lot of these common triggers out. We see if you're improving on this low FODMAP diet, and then we systematically reintroduce the foods while we assess your symptoms and see how you're doing. At the end of this, we personalize your diet and really try to give you guidance on what you're able to eat, how much you're able to eat, and kind of show you the way to manage your symptoms through your diet. I like to think of these foods and your digestive system almost like a bucket. So at the end of this, again, we don't want you to be on a low FODMAP diet forever, because it's a little risky. We don't know the risk of being on this elimination diet long term. We want to try to rebroaden your diet and give you guidance to allow you to have some of these foods here and there. Again, I like to think of it like a bucket. You might be okay with a little piece of cheese or a couple black beans sprinkled on a salad, but you do cheese, black beans, broccoli, Brussels sprouts all in one day. You overload your bucket and the symptoms pour forward, and you start to have a lot of pain, bloating, and gas. So different than the allergies, these food sensitivities definitely can contribute a lot to symptoms, and it can be a bit labor intensive figuring out what your triggers are, but it can lead to a lot of successful help. Fiber is one of our main tools that we use in patients with IBS. It's often used to treat these global IBS symptoms. I like fiber because it often does what you need it to do. If things are too loose, it often binds up the stool. And if things are too hard, the fiber often pulls water in and helps with a gentle laxative effect. It can often be a bit of a trial and error to find the right type that you can tolerate. If you already don't eat much fiber, and then you jump up to the recommendations, which are 25 to 35 grams of fiber a day, you may be a little uncomfortable, bloated, and gassy. So again, working with our team can be really helpful to help you find the right fiber for you. There are two types of fiber, soluble and insoluble, and we use them for different categories of IBS. Soluble fiber is best for IBS with diarrhea. These are things like oat bran, squash, carrots, melon, avocado, citrus. And the supplements Citrusel and Benefiber are in this category. And insoluble fiber, which are best for IBS with constipation. So flax seeds, leafy greens, berries, nuts and seeds, and FiberCom. The fiber is really important because it really does affect your gut microbiome, your metabolism, the transit time of the digestive products, the consistency of your stool, how bile is absorbed, and they increase the stool water content. Specifically, IBS with diarrhea. We focus again on figuring out your triggers. Is there a certain food intolerance or a stress? Is your microbiome out of balance? Is it a motility issue? And if we haven't had success managing with the diet and lifestyle changes, then sometimes we'll use some medications. So antidiarrheals are used basically to slow the speed at which things move through the colon so the colon can do its job and absorb all that water. So your stool is less liquid and easier to hold on to and passes less frequently. So there's the over-the-counter Imodium or loperamide, which many people are familiar with, which actually, when you're working with your doctor and it's not an acute diarrheal episode, is a safe thing to use on a regular basis. We also have prescription strength antidiarrheals that focus on a similar receptor, kind of like if you had knee surgery and you were put on a narcotic to manage pain and then you get bound up. These prescription strength antidiarrheals bind to that same receptor that those pain medications bind to, but they don't give you the loopiness that the pain medicine would. There are also medications called antispasmodics. These are your old school IBS medications that help with cramping and pain. They're not great. There's not great data around them, but we do use them often because in certain patients, they can offer significant relief. And then in the last few years, there's been an antibiotic that's been approved that's used to reset the gut bacteria and specifically has been shown to improve IBS with diarrhea symptoms. Specifically for IBS with constipation, again, we're focusing on fiber, diet, water, behavioral changes. Very important to figure out if patients are ignoring the call to stool. Are you feeling the urge to go, but you're too busy in a meeting and you're ignoring it and then you can't go later? That's something to pay attention to. Sometimes we'll even recommend lovely things like this position when you're having a bowel movement. The brand name is the Squatty Potty. I don't endorse them specifically, but the position where your knees are above your hips actually may relax the muscles in the rectal area and allow you to pass the stool easier. If these behavioral things aren't working, then we move forward with the laxatives. Sometimes we use over-the-counter laxatives. You just need to work with your doctor and be careful because certain laxatives you can develop a tolerance to and require more and more to get the same effect. I like to point out senna. It's often used because it's considered natural. It comes in teas and different supplements, but this is one of the ones that you can become a bit dependent on. Magnesium is a good option for over-the-counter. And then we go to the prescription strength constipation medications. Again, we used to wait till you failed all the over-the-counter therapies, but these medications called secretagogues have been shown to actually improve global IBS symptoms. So not only do they help you poop, but they help with abdominal pain. We also have another category of prokinetics that can move along the motion of the colon and move stool along. And as I mentioned before, making sure there's no element of pelvic floor dysfunction contributing to symptoms is really important. Last but not least, we focus on the gut-brain axis dysfunction itself. So it can be a vicious cycle. You're anxious and it throws off your digestive tract and you end up with your abdominal pain and your gastrointestinal symptoms. Then that flips you into more anxiety because you're uncomfortable, you're worried about what's going on, and it can be a vicious cycle. So we often need to work with behavioral health specialists to retrain our brain to manage symptoms and to re-educate us that although these symptoms are extremely disruptive and distressing, they're not dangerous. So these therapies that have been used for depression, anxiety, chronic pain syndromes are now being used for IBS and have pretty significant effect on patients. Cognitive behavioral therapy, hypnotherapy, and mindfulness meditation. Sometimes we'll go to medications to help with this gut-brain axis dysfunction. We need to dampen down that response that the nerves are sending to the brain and reset that pain loop. Neuromodulators are basically a category of meds that are traditionally used for anxiety and depression, but we use them for IBS specifically because you have these nerves and these receptors lining your digestive tract. And using these medications has really been shown to help with symptoms of IBS. We often try to choose the medications based on their side effect profile. So if you're already constipated, we're not going to put you on a medication that's going to cause more constipation, but we'll happily use that for a patient with IBS-D. Down the road, there's a lot of promising studies on things like acupuncture, neurostimulators, and other interesting things to kind of disrupt this abnormal feedback loop. Supplements. So hot topic, huge industry, billion-dollar industry, where a lot of people are gobbling up these supplements and not really consulting with their doctor. So in general, there's no blanket guidelines for supplements for IBS. There's not one supplement that anyone should be on. The tough thing about supplements is they're not FDA studied or approved, and they do carry some risk. Some of them can significantly increase your risk of liver toxicity. We do find some success with supplements such as peppermint oil, fiber supplements, and magnesium. But even peppermint oil, which seems very benign, could flare up acid reflux symptoms. So it's always important to discuss these with your doctor. Unfortunately, there's poor data right now on some of these other supplements that are being used very regularly, such as probiotics, turmeric, artichoke leaf extract, celery juice, and cannabis. So studies are ongoing. Hopefully they will turn positive someday and we'll have more tools in our belt, but supplements in general on a case-by-case basis may be recommended and used. I went through a lot in a short amount of time. I just want to wrap up by going over a few key takeaway points. IBS is a disorder of the gut-brain axis, no longer called a functional gastrointestinal disease, but a disorder of the gut-brain axis. The baseline symptoms include abdominal pain, change in your bowel function, and often bloating. All patients have different symptoms, and thus treatment is different for all patients. It is not life-threatening, but it can be life-altering, very distressing, and chronic. It's really important to have a consultation with your primary care doctor or your gastroenterologist, preferably, to rule out any of these red flag symptoms that would make us want to investigate further. And working with a treatment team is really, really important to start you on the path to healing with lifestyle, dietary, supplement, medication, and behavioral health support. And we're here for you if you feel like you fall into any of these categories. Okay, so Dr. Oroku.
Thank you,
Yes.
Dr. Laura Fredo, for an excellent tour de force over a topic that is quite literally a pain in the gut for a lot of our patients. But we're happy to be walking with them alongside their journey with us. We have a lot of participation in the Q&As, and so I'm going to call some of the questions. Again, I will apologize in advance. We don't have time to answer all your questions, but we'll get through as many as we can. And just a general reminder, of course, this is not a one and done. We're here. We're your local gastroenterologists, and so feel free to reach out to us and come to see us for consultation for these issues as well. All right, so we'll start with the question we have here. This question says, can IBS symptoms be brought under control through proper nutrition alone? Can IBS symptoms be brought under control through proper nutrition alone? What are your thoughts about that?
I would say yes, in certain patients, it can be, because I had all those categories of different things can contribute to symptoms. And sometimes it's just the food sensitivity alone that's driving your IBS symptoms. So 100%, we do the elimination diet and try to pinpoint what your specific triggers are. And then by formulating a more specific diet for you, you can really gain control of your symptoms again.
That's great. All right, we'll take another question. This question is in regards to your description of pain being the characteristic aspect of IBS. And so the person says, hello, Dr. Fredo. If someone has constant upset stomach, bloating, gas, does that qualify as pain, which you've noticed is the main characteristics of IBS? And he or she says, thank you for answering the question.
Good question. So if it is if the bloating and that pressure sensation is uncomfortable to you, then yes, I would classify that as being painful. Some people eat a Thanksgiving dinner and have a big distended belly and are very happy with themselves and very comfortable. And that is not a painful experience for them. So yes, I would say if you're having trigger symptoms that are triggering distension, gas that is uncomfortable, but it's also associated with a change in your bowel movements. That classifies as IBS. There's a whole nother category of this gut-brain interaction that is abdominal pain, but not associated with change in bowel movements. So some people experience what's called functional dyspepsia, or functional pain in the upper digestive area, but no change in bowel movements. And that's in the same family, the same category of the brain gut interaction, but a different category that's managed a little differently.
Great. So thank you for that question. All right. Another question, as we give you a second to take a sip of water.
Talking a lot.
Exactly. So this question says, how is SIBO treated? And again, as a reminder, SIBO is a small intestinal bacterial overgrowth. And their question is, how is SIBO treated?
Great question. So traditionally, we first diagnose it with a breath test, where we actually give you a sugar solution to drink, and then we measure the byproducts that come out from your breath and see how well you're able to digest those sugar contents. If it comes back positive, we do a combination of antibiotics, and we try to, again, reset the gut bacteria and calm down that bacteria burden. Depending on the results of the breath test you had in the first place, we may do one antibiotic. The classic one we use is one called rifaximin or Xifaxan. It's not systemically absorbed, so it's a really safe antibiotic that we have. And then sometimes we'll combine that with other antibiotics. And then after you go through the antibiotic course, we try to make sure we figure out what the underlying cause of your SIBO was and try to prevent it from coming back again. Any thoughts on that, Dr. Rocco? Anything you do differently?
No, I think you covered it. I think it's one of those things that we think about when we're thinking about IBS, which is why I thought it was important to tackle it. And we have another acronym that we'll tackle in our next question. But yeah, sometimes it's a matter of doing the breath test. Sometimes it's a matter of empirically giving you the antibiotics and see if that works. And sometimes
we've been doing that a lot this year with COVID, because we're not able to do the breath test. We don't want people blowing in our medical assistant's face. So if we have a high suspicion, we sometimes will give you the antibiotics.
That's right. And so our next question, again, on the acronym part of the spin the wheel, is regarding IBD. And you covered it a bit before, but if you can just, again, explain to the audience, what's the difference between IBD and IBS?
Great. So IBS and IBD are often confused because they sound very similar, and they do have some overlapping symptoms. So both groups of patients sometimes will have abdominal pain and diarrhea. But the big difference with inflammatory bowel disease is in the name, inflammation. So when you get testing done, you have blood work, stool studies, and then when we do colonoscopies or endoscopies, we see active inflammation in the lining of the intestines. And this is only seen in inflammatory bowel disease. Like IBS, it can come in a spectrum. So it can present as Crohn's disease, which can affect any part of the digestive tract, or ulcerative colitis, which primarily only affects the colon. And it can be a very similarly lifestyle altering and debilitating disease, but unfortunately it can progress to complications. So things like requiring surgery, and it's also treated very differently. You're treated with very specific medications to calm down the inflammation and also suppress the immune system, because there's an autoimmune component that's driving the inflammation. So very important, especially when you're talking to your families, if you're getting a history. Is it inflammatory bowel disease like Crohn's or colitis? Or is it irritable bowel disease, where it's more symptoms and background of pain, but no inflammation underlying it?
All right, we have a lot of questions about the end of IBS, because again, a lot of our patients are dealing with it, and they are understanding, maybe some of the origins, they're understanding some of the journeys of treatments. And a lot of questions popping up in the chats are regarding when does it end? And so one question says, can you outgrow IBS? Another said, with treatment, will IBS be cured? What's your, just from thinking about your experience over time taking care of people with IBS, what's your experience with that?
It's a great question. I would say that it's different for everyone. It can be a chronic condition, but it definitely can wax and wane over time, depending on what you're going through and how you respond to the different treatments and how you manage it. It can be frustrating because nobody wants to be labeled with a chronic disease, and nobody wants to know that they're going to live their whole life like this. What I will say is a lot of the research that's being done right now is so promising that I think that I'm hopeful in the next 5-10 years, we're going to learn even more about the microbiome and potentially have very specific dedicated targets to treat. And again, managing and understanding the way the brain and the gut interact. We're just at the forefront of understanding that. So I think these things, I'm very hopeful that there will be better management and hopefully even a cure for specific causes of it down the road. What do you think, Dr.
Yeah, no, I agree. And I think that it ties in another question here that I'll begin to answer as well.
Sure.
This one says, we're told that IBS is not dangerous. So this person is having, a positive outlook and saying it's not supposed to be one of the more concerning diagnoses, but can it cause nutrient deficiencies? Is it possible for you to have such a fast passage of content through your intestines to the point where it's not allowing for proper absorption? I will say that personally, when I checked for nutritional deficiencies in my patients, as I often will, I haven't found consistently that that's an issue with my IBS patients. And so I understand you're thinking maybe the passage through the gut may be so quick that there may not be time for absorption, but the content, the food we eat in its different forms, kalkine, et cetera, exists in our nutritional gut system for quite a period of time. And there are many touch points for absorption. And so in my experience, there really hasn't been a high level of nutritional deficiencies in my IBS patients. Do you have any thoughts on that?
I 100% agree. If you were having malnutrition, you would have some of those red flag symptoms that would make us want to investigate further. So if you're not absorbing food, you're going to lose weight. If you're not absorbing the proper nutrients, you may develop iron deficiency or other lab abnormalities. And that would make us want to investigate further and rule out actual causes of malnutrition.
All right, so this is another definition one, but I think it's important to address these just because if one person is asking the question, many people probably are. So this person says, is there a relationship between irritable bowel syndrome and ischemic colitis? In your opinion, have you seen a relationship between those two?
I have not seen a direct relationship with the two. Ischemic colitis is a condition where, for whatever reason, there's a sudden loss of blood flow to the colon, and it presents with a sudden onset of abdominal pain and sometimes diarrhea and sometimes blood in the stool. So luckily, IBS does not predispose you to getting ischemic colitis, and there's no, that I'm aware of, relationship.
Great. All right. So this question is asking about your experience with IBS type. Can your type of IBS change over time? Have you seen that?
I definitely have. I am thinking of patients right now who they're, when they were younger, they were always running to the bathroom. And specifically, I think there may be something to be said with hormones. As women go through menopause, they notice a change in the speed at which things move through their system, and they may flip to the constipation side. Definitely can flip-flop and be very frustrating for patients, but it can happen, yeah.
All right, we'll take a few more questions. All right, this question says, hello, Dr. Fredo. How early can you find IBS? Or question is maybe, what are some of the earliest ages you've ever seen it? And if caught early on, can you avoid future symptoms and future gastro issues? And this person says, also, thanks for being an amazing doctor. So
very sweet. Thank you. I love my patients.
that's great.
So amazing question. I believe that it can occur in children, but it often develops in adolescents and teenagers. That's where it really starts to blossom, but it can be seen in kids. Diagnosing it early, I think, is huge because, for example, chronic constipation can end up being a vicious cycle that could lead to problems down the road. And your colon actually almost has elasticity to it. So if you're really chronically backed up, it can be hard to get back on track. So I think that, pinpointing these things early will only help you in the long term manage and prevent, the side effects of the stress and anxiety that IBS brings about as well, and thus that vicious cycle. So I think it's a great question. I wish we had a pediatric gastroenterologist on our team. We could get their input maybe down the road.
That's right. All right, we'll just take a few more questions. There was a good question here. I'm scaling through the Q&A to find it, but the person's question was on a very practical level. Do you find that there's any major difference in the ways that you manage someone with, chronic constipation, idiopathic constipation, and the way you manage someone with IBS, with the constipation predominance? Or do you find that you tend to use the same thing for both categories? What are your thoughts on that?
It's a great question. So there's a lot of overlap with the treatment, definitely, because chronic constipation alone, we want to figure out, are you not eating enough fiber? Are you drinking enough water? Is there something in your diet that's binding you up? And then we move forward with the over-the-counter laxatives, the fiber supplements, and then the prescription strength laxatives. So these prescription strength laxatives that happen to also help with abdominal pain for IBS are also used for constipation, idiopathic constipation. So the constipated patient who's not having these severe abdominal pain episodes like you'll have with IBS. Again, I would say the majority of patients with constipation, it's what's called slow transit. So it just takes a long time for things to move through the colon. The colon does its job of sucking all that water out, and then the stool becomes hard, and it's a vicious cycle, and it's hard to pass. But again, it's really important to rule out any of these pelvic floor disorders that may be contributing to constipation as well. So definitely checking for these things in our IBS and our constipation patients is really important.
All right, so we'll end this session with one last question. And I'll start by, again, apologizing for the many, many excellent questions. I'm scaling through. There's so many excellent questions here. Again, to remind you, New York Gastroenterology Associates is not going anywhere. If anything, we're here to stay, and we're growing bigger by the day. We currently have up to 5 sites, including expanding out to Brooklyn Heights. That's our most recent expansion. And we're currently up to 15 doctors. So if you blinked over the past couple of years, yes, we're no longer just 4 or 5, we're up to 15 at this point. And so again, New York Gastroenterology is here, and we'll be here to answer your questions. So feel free to go on our website, set an appointment, call the office, and we'll be happy to help you with your journey. But I thought it'd be great to end on a personal question that someone asked. Don't be too scared. The question is, I'm curious, Dr. Fredo, why did you become a gastroenterologist? What's your answer to that question?
Great question. So it's not only because I like to talk about potty jokes once in a while, but you do have to have that sort of attitude. But it's really because everyone struggles with digestive issues at some point in their life, and having someone who you can actually have a conversation with and who can listen and try to get to the root of it, I felt like I could offer that service to my patients. I also thought it was important to, it's a very male-dominated field, so I knew that a lot of patients like to speak to a woman about these sensitive issues. So I thought that would be a good service to provide to my patients as well. And it's a procedural field, which is very satisfying as well. We do endoscopies and colonoscopies and really can diagnose things and fix things and help people in that aspect. And then the last thing is, I have a lot of reasons. I love my job. So the last thing is the preventative health part of it. Colon cancer screening is so important. We can prevent people from dying from colon cancer with our colonoscopies. So lots of reasons I went into GI. I'm very happy with my choice. What about you, Dr. Oroku?
Many of the same things. I think, we get to really walk alongside people long term. So I like the fact that this is a long-term relationship, can be in some cases for people with chronic issues. And for people who just need to see us from time to time, maybe for screening colonoscopies, it's great to learn the expertise to do an amazing job and to really leave them wowed with how amazing the experience was. Oftentimes people will wake up and say, that was easy. That was great. And again, these are things we hear all the time. So it's a great and gratifying field in that regard. So again, Dr. Fredo, thank you for this amazing tour de force on this important topic that affects not only a lot of our patients, but a lot of America, really. And so that was amazing. And again, we just want to remind you all that New York Gastroenterology, we're here for you. You can go to our website at nyga-md.com and sign up to see one of us, and we'll continue to take care of you over the weeks, months, and years to come. All right.
Thank you all for tuning in. Have a nice
Signing off. Take
Bye-bye.
care.